to welcome you to this side event focusing on advancing gender equality in health. So, next slide. Just to give a bit of context, I think as we've all heard over the last 2 days, although some progress has been made with regards to the Beijing Platform for Action, it's very clear that the current context of ongoing multiple concurrent crises, either political, economic, social, and environmental, alongside transnational anti-gender movements, are having detrimental effects, not only on gender equality, but also on health equity. The health and well-being of millions of women, girls, but also gender diverse individuals and other structurally excluded groups is being negatively impacted, with a greater strain on health systems, especially the health workforce and the women who are at the heart of it. So now more than ever, there is a need to learn about what works, but just as importantly, what doesn't work in diverse country contexts with regards to gender integration into health programs that have been scaled and sustained. And I think this is a really critical point in the discussions today. Furthermore, there's a real need and urgency for meaningful collective action to ensure that progress towards gender equality and health equity remains central in the face of these competing crises and competing priorities. Over the last 4 years, UNUIIGH, which is a global health think tank within the UN system, dedicated to advancing health equity and improving global health systems through policy-relevant research, has built a portfolio of work through its Gender and Health Hub, with partners within and outside the UN system to fill this gap. And in particular, I'd like to draw your attention to 2 pieces of work that UNUIIGH has led in the context of the discussions I hope we're going to have today. So next slide. The first is 2 commentaries that were authored by a high-level advisory group. And the high-level advisory group, which Gita-san kindly co-chairs, includes heads of 6 UN agencies: UNAIDS, UNDP, UNICEF, UNFPA, UN Women, and WHO, alongside the UN High Commissioner for Human Rights, the UN Special Rapporteur on the Right to Health, as well as distinguished experts and leaders from civil society on global health and rights. And these 2 commentaries in particular are important given the urgent need for global health leadership to remain committed to safeguarding against the rollback and pushback that we're experiencing vis-à-vis gender equality in health. In particular, the most recent commentary, which you can see there, and hopefully you all have either on the table or in your packs, is a call to action, specifically stressing the need for 3 things. One is the increased need for funding and support to strengthen investments, partnerships, research, all led by grassroots communities and feminist women-led civil society organizations. The second is improved alignment across institutions and movements for equality and rights to counter existing fragmentation and polarization, which I think we're all seeing at the moment. And lastly, and importantly, is the need for macroeconomic responses at global, regional, and national levels really formulated to support gender equality and women's rights. Next slide, please. The second piece I want to draw your attention to is a series of case studies we led alongside PHFI, the School of Public Health at the University of Western Cape in South Africa. And these case studies sought to understand the politics of change, what spurred successful gender integration into government health programs and policies. And there were 6 case studies as part of the series, 4 of which are from the region. And these include looking at gender integration into the largest tertiary hospital in northern Philippines, as well as the Safe Abortion Act in Nepal. And I encourage you all, if you have time and when you have time, to scan the QR codes provided to read the full reports. So as we kick off this session, and I don't want to take more time, I just wanted to flag these pieces, and hopefully you can keep them in mind throughout the discussions today. So on that note, I think enough from me, and I'd like to invite our two keynote speakers to give their keynote remarks. First is Chair Valdevilla, who's the chairperson of the Philippines Commission on Women, who's kindly joining us in person, and you've probably heard her speak already in several sessions in the plenary hall upstairs. And the other is Dr. Sangeeta Mishra, who's joining us online from Nepal. And Dr. Mishra is the Additional Secretary of Health, Ministry of Health and Population for the government of Nepal. So, Chair Valdevilla, over to you.
Thank you very much. Good evening. I think it's evening already. And blessings of peace and good health to everybody. We live in a world of intersecting crises, and crises impact populations differently. When crises multiply, injustices prevail and disparities widen, pushing vulnerable sectors, especially women and girls, with intersectional disadvantage to the brink of dehumanization. This is profoundly manifesting in the health sector due to weak gender perspective, low regard for women's health, and their underrepresentation in policy and decision-making. There are many drivers of women's disadvantage in the health sector. First, the CSW 68 confirmed the sharp increase in the number of people living in less than $3.65 a day. And if the projected upsurge of poverty continues, over 340 million vulnerable women are projected to slide into poverty by 2030. This could force them to choose between basic necessities and medical treatment. Second, unpaid domestic work and care fall disproportionately on women, straining their time, their energy, and well-being, especially during health crises. Third, as the world's population ages and life expectancies improve, women continue to dominate the highest age of elderlies. Women worldwide generally spend the best years of their life caring for others, but at this age, when they could no longer provide care even to themselves, who will take care of them? What is the game plan of the world to care for the aging women carers of humanity? Fourth, during the pandemic, response and recovery focus on austerity policies, debt repayments, displacement, and other crises. This focus sideswept increases in gender-based violence, narrowing of safe spaces, and women's restricted access to health care. Since women and girls' health tend to be marginalized during health crises, policies and interventions for their health rights must be in place, ready for activation whenever there are crises. Fifth, a 2023 Women in Global Health report showed that women only hold 25% of leadership roles in health, even if they are the majority of health practitioners, and a 24% gender pay gap in the sector exists. This is discrimination, and it must be over. It should be ended. Sixth, climate change impacts heavily on women's health. The mortality rate among women during natural disasters is significantly higher than that of men. Environmental crises also bring about disruption in reproductive health services, such as limited access to contraception and maternal care, which increases unintended pregnancies and maternal deaths. Finally, the pandemic shook the world to a realization that in the face of extreme global humanitarian situation, the care work of women stands as a pillar of human survival. It also demonstrated that the world is not prepared enough to secure the health of those who take care of public health, who are mostly women. In the world of intersecting crises, a gender-responsive health system and a healthy populace stand as a robust line of defense. Let us therefore remind authorities of these lessons and drive forward the imperative of investing in women's health and their roles in the survival of citizens, both in paid and unpaid capacities. In a world of polycrisis, investments in women's health makes good governance even better because it gives humanity a better fighting chance against crisis. Thank you very much.
Thank you so much, Chair Army. We're going to go now to Sangeeta, who's joining us online, and hopefully Sangeeta will be able to see you in a moment. So I think we can switch screens and take down the PowerPoint for a minute.
Hello.
Can we pin
Hello.
Mishra, please?
Can I
Yes,
speak?
we can see you. Let me.
Yeah. Can you hear me?
Yes.
Is it okay?
Perfect. Yes, we can hear you.
Yeah. Okay. So, dear delegates, colleagues, and honored guests, a very good evening to all of you. It is a privilege to speak to all of you today. The relationship between gender and health is so profound that it not only affects the individual, it also affects the communities. It also affects the country as a nation itself. In the last few decades, Nepal, a country with cultural diversities and challenging geography, has made significant progress in addressing gender disparities. Let me walk you through this journey and share some of the lessons that we can draw from Nepal in future in advancing gender equity in health. So Nepal's journey of gender equality began in the shadow of deep-rooted gender inequalities. Historically, women faced limited access to healthcare due to socio-cultural barriers, geographical isolation, and socioeconomic disparities. And all these factors, either in isolation or in combination, often restricted women's mobility and limited their decision-making power. I will just quote one data. In 1996, the maternal mortality rate in Nepal was 539 per 100,000 live birth. I will not share all the data, but I'm just trying to say that the scenario in which Nepal was in last 4 decades and the journey that Nepal continued has significant milestones. And it has been marked by civil advocacy and movements, political realizations, transformative policy and programmatic changes. And all of these in combination has led to significant milestones and achievements. I will just speak about few of them. The most important focus which Nepal took was on focus on reproductive health. The maternal and child health became national priority, leading to a significant progress in health of the women and girls. The access to safe abortion services and family planning services empowered women to make informed decisions about their reproductive health, protecting women's autonomy and health. I would like to urge all the delegates to read the Nepal case scenario where we have given a full account of Nepal's safe abortion movement and how the abortion was legalized in Nepal. The programs like Safe Motherhood Initiative and Free Maternity Service also added to this focus and improved the maternal mortality. The next key turning point was community-based initiative. One of the Nepal's greatest strength has been its emphasis on community-driven approaches. The Community Health Volunteer Program, which is commonly known as FCHV program, which was established in 1988, became a cornerstone of Nepal's health system and added huge success to maternal and child health program. Currently, we have 52,000 female community health volunteers for 30 million population. The other community-based programs like expanded program on immunization and integrated management of neonatal and childhood illnesses also ensured that community-based identification of the illness and their urgent management, promoting early health outcomes. The third keystone was legal reforms. Nepal has made significant progress in ensuring women's health rights. The legalization of safe abortion in 2002, which marked a critical step in protecting women's autonomy and health, Domestic Violence Act in 2009. These two legal reforms were a cornerstone and they were a key turning point for the nation. Even the interim constitution of Nepal, 2015, has mandated for essential service provision in MCH. Similarly, there are other Safe Motherhood Reproductive Health Act, Public Health Act, and National Gender Equality Policy 2020. All these legal instruments ensured equitable access to healthcare for women, reduced gender-based violence, including those in remote areas and in disadvantaged communities. The fourth key point was gender-sensitive policies and strategies. Nepal recognized that addressing gender inequalities required systemic changes, and they brought many policies and strategies in the meantime. And the most recent one, gender-based violence strategy and gender equality and social inclusion strategy, which has integrated gender consideration in all aspects of health, planning, and development. The fifth and the most important key turning point has been gender-responsive budgeting in health. In Nepal, gender-responsive budgeting has been a cornerstone of efforts to advance gender equality in health sector, ensuring public spending addresses gender disparities and promote equitable healthcare access. With these key turning points, Nepal achieved quite a lot of success. And in the last census, we did a maternal mortality study. We said that recent maternal mortality of Nepal is 151 per 100,000 live birth. So what did we learn from these practices? In these 4 decades, there were significant learnings from our country. The most important learning which I would like to highlight here is community engagement. Community engagement is the key to success. As I already said about Female Community Health Volunteer Program, which highlights the importance of engaging communities in health service delivery and decision-making. Empowering women at grassroots level as health advocates builds trust, improves healthcare access, and bridges cultural gaps in rural and underserved areas. Addressing maternal and reproductive health yields significant results. This is our second key learning. Prioritizing maternal and reproductive health programs delivers tangible results in improving overall health outcome and in reducing gender-based disparities. Third learning has been gender-sensitive policies enhance equity. Gender-sensitive frameworks are essential for addressing systemic barriers to healthcare access and ensuring inclusivity. The adoption of gender equality and social inclusion strategy has highlighted the importance of integrating gender considerations in health policies. Fourth important learning has been legal reforms. The legal reforms play a crucial role. Legal frameworks that protect reproductive rights and address gender-based violence are critical for advancing gender equality in health. Legalizing safe abortion in 2002 and implementing laws to address domestic violence in 2009 have improved women's autonomy and access to essential healthcare services, and this has led to greater health equity. Gender-based violence services are life-saving. In Nepal, we have one-stop crisis management center. These have been established for integrating gender-based violence services in the healthcare system. And these OCMCs have provided essential support for the survival of gender-based violence, linking healthcare and psychological as well as legal services. Overcoming cultural barriers and tackling social determinant is also very crucial. Culturally sensitive and gender-inclusive approaches are necessary to address societal norms that restrict access to healthcare, improve education and economic opportunity, as well as the infrastructure. It significantly enhances access to health services for women and marginalized groups. Partnership, amplify impact. This has been one of our major learning. Partnership bring additional resources. They bring expertise, the advocacy power to address gender inequality in health. Collaboration with international organizations, non-governmental organizations, and civil societies has helped Nepal to scale up gender-focused health initiative and lead to legal reforms. Strengthening multi-sectoral and international collaboration is the key for accelerating progress. And last but not the least, our final learning has been continued investment is crucial for sustaining the progress. Continued and sustained funding of reproductive health program and gender-based violence program are utmost essential to sustain the results and consolidate the hard-earned gains. So in conclusion, I would just like to highlight that Nepal's journey to gender equality in health is a story of progress driven by communities that embraced change, by women who led the way as healthcare volunteers, our FCHVs, and healthcare workers, and also by civil society and policymakers who dared to challenge the status quo. Ongoing efforts, advocacies, close consideration of social determinants of health and strengthening of health system are needed to ensure the sustainability of these results and expanding the reach of underserved population, especially marginalized women, in achieving gender equality in health and universal health coverage. Thank you so much.
Thank you so much, Sangeeta, for that keynote. And in the interest of time, we do have a fantastic group of panelists joining us today. So I'll quickly introduce them and then hand over to our moderator, Geeta Sen. On the panel today, we have Vice Mayor Leo Candido, who's the Vice Mayor for the municipality of Quinponduan in Eastern Samar of the Philippines. We have Samantha Hung, the Director of Gender Equality at the Asian Development Bank, and Ms. Sivananthi Tanentharan, who's the Executive Director of the Asia Pacific Resource and Research Center for Women. And the moderator is Professor Geeta Sen, who probably doesn't need an introduction. As you all know, she's a Professor Emeritus at the Indian Institute of Management in Bangalore, the former director of the Ramalinga Swamy Center on Equity and Social Determinants of Health at PHFI, and on the executive committee of DAWN, the Development Alternatives with Women for a New Era. So can I begin by handing over, please, to Vice Mayor Candido, and we can share his slides.
Okay, thank you, Ms. Joanna. Do I have the floor? Yes. Okay, thank you. Good afternoon, everyone. I'm Vice Mayor Leo Jasper Candido from the Philippines. I am here to share the Women Economic Empowerment Care Ordinance on the implementation of care support services in our locality. Next slide, please. Well, just to let you know where I came from, here are the quick facts. We are a fifth class municipality and we have a population of more or less 15,000. And we have fishermen and farmers as their day job. As you can see in the picture, we are facing the Great Pacific Ocean, in which, as I always say, we are the welcoming party of the typhoons. Just in the last 4 weeks, we have 6 typhoons in the Philippines. So we welcome them all. Okay, next, please. Now, how did I become involved in the advocacy of care work? First, I drafted local legislation. In our term, it's called ordinance, recognizing the unpaid care and domestic work in our community, wherein basically it is left undervalued. That's why the local government's action is to give what is the best support that we can have to uplift their lives, and how do we and the interventions that we can help. Next, please. So an ordinance is local legislature in which it has a permanent in nature. So basically institutionalizing the local legislation makes it permanent that even when the term of an official ends, it will sustain to in another years. It will remain unless it is amended or repealed. Next. So this is basically the part of the ordinance. The ordinance objective is based on the quadruple R framework. You maybe already know this: recognition, reducing, redistribution, and what's that? Representation. So first is the data collection. We collect data based on CBMS as to the number of hours that the care workers, especially the women, do in our community. And we make it as a basis for policy making and other programs that we can make intervention. Second part is the shifting of social norms. This is the part where information and education campaign that we do with the students in our municipality as to shift from the social norms of the society. Third is the time and labor saving equipment. We give this just to lessen the burden of the care workers in the community, but we give this with together with the IEC campaign. Next is the care services. There are three care services that we focused. One is the access to safe water. Another is daycare centers, and next is health services. In the health services, we have capacitated community health workers who are mainly volunteers to conduct time-targeted care for families in which they visit the family of pregnant women, lactating women, children under 2 years old, and they give vitamins or orientation on what to do in the house and what is the shared responsibility of all the members in the household. Also, for the senior citizen, we have the health support for the senior citizens, in which the objectives are to home care support to the senior citizens in their own homes and establish and sustain program services for senior citizens, enhance capabilities of implementing senior citizens organizations in delivering the basic services to home care beneficiaries. So we also have a budget for senior citizens for their medication, an ample amount of 1,000 pesos for every 3 months. It's just very little, but it helps to start. Uh, it is used for buying medicines and other stuff that they need. The next part is the financial mechanism, which is very, very important because in the implementation of this local legislation, it needs fund to implement. Unfortunately, we only allot 100,000 per year to implement the whole program. So uh, building a resilient care system requires a long-term investment, sustainable resourcing, collaboration and innovation, and our local government unit is committed to work with community partners and stakeholders to identify areas for improvement and implement impactful solutions to achieve the goal of this ordinance. And for my last statement, it is the poorest among the poor families that are the ones mostly affected by inadequate care services, such as water and health. Instead of investing their time into other income-generating activities, leisure and religious activities, they spend an extra amount of unpaid care work that traps them further in poverty, exacerbated by the huge gap in wealth and income between the rich and the poor. In our locality, our ordinance has been one of our ways forward to help the communities fight inequality and address economic justice through recognizing and valuing the unpaid care work in our municipality. Thank you.
May I stand?
Please,
Is there a remote clicker or should someone else?
there's someone
maybe
doing
this
it
will work.
remotely. And there should be a.
Oh yeah, this works. Hi everyone, Samantha Hung.
Connected to the internet? Yes.
There's a mic, so it should be okay. I thought I'd stand, just it's late in the day, a bit more energy. So Samantha and I lead the gender equality team at the ADB. If I could just move to the next slide. So for those of you who may be familiar or less familiar, ADB works basically with governments and also private sector, but on a sector basis. And we've always invested in the health sector, but really it was the pandemic which really put a spotlight on our health sector operations for obvious reasons. And we all know that the pandemic had particular gender dimensions, both in terms of the care burden, but also some of the barriers it placed to women accessing their usual health services, but also increased burden on mental health. So what I'd like to do is, from a gender specialist perspective, we have a strong commitment to gender mainstreaming. So we always look for whatever opportunity we have to maximize gender results or interventions through our projects. So the pandemic, we very swiftly responded with some new modalities. One was something called the CPRO, which is a COVID pandemic response option, which is basically budget support to governments to help them deal with the pandemic. And it was basically in three main areas. One was health sector response, one was economic stimulus, and one was social protection. We also had something called AppVax. Actually, that's a typo. It should be AP. AppVax, which was a new modality to help roll out vaccines in the region and sometimes emergency assistance. So what we did is wherever possible, we made sure that we did not allow for further gender disproportionate impacts. So for example, being women were at the front lines of the health sector response. So we ensured through that we supported women's health workers through, it could be, some of it was really practical things like making sure that health systems procured right-sized PPEs for women health workers and not assuming that it was a one-size-fits-all, making sure that health workers had the support systems, that they had transport to and from work, some really practical things. Through our vaccination response, we also, in addition to COVID vaccine rollout, as much as possible, used it to promote things like HPV vaccine access at the same time. And we also, as much as possible, tried to make sure that sexual and reproductive health services were not let go as a result of shifting budgets. So these are the kinds of things we negotiated into the package. So if I can move forward. So that is really, to the next slide, it helped us take a stock take of what we were doing on gender across our health sector operations. So I was just, there's very little time, so I'll just quickly walk you through some of the things that we do. So obviously a focus on sexual and reproductive health rights and using the health system to draw attention to GBV wherever possible. So these are two examples here. So in Tajikistan, we're supporting a maternal and child health integrated care project, but through that project, we're raising awareness about the linkages of GBV so that health sector providers are trained to be able to give the right referral services, identify where there might be GBV cases, and also use the existing facilities that are already there but are not being used. So for example, in Tajikistan, maternal health wards are meant to be a resource and a safe space for GBV survivors, but nobody uses them for whatever reason. So it's drawing attention to those things. Similarly, this other project is in Kiribati. It's about health infrastructure, predominantly about infrastructure, but through that, we're also doing comprehensive training on sexual reproductive health rights and GBV through multimedia, including engaging with men and boys, so that there is a greater health sector response. On the next slide, another way we're doing this is really drawing attention to the gender, health, and climate nexus. One recent area of work that we have a large technical assistance on is really understanding the gender impacts of heat stress. The whole region is boiling. It's a huge issue for many of our developing member countries, but the gender impacts of that are not very well understood. Where there is some good data is actually biological, and that relates a lot to the disproportionate impact on pregnant women and on neonatal outcomes. So we have this multimedia site there. We're supporting quite a lot of research in the space, which is partly health, but it's also about urban planning. How do you have gender responsive spaces to build heat resilience? And we have some health projects, such as this Uzbekistan one, where we're integrating awareness about the impacts of climate and heat on perinatal care as part of the communication. Next slide. Another area is about capacity of health workers and health systems. So here we have two projects from India. So the Maharashtra one, I saw Maharashtra somewhere on the screen before. I'm not sure if this is remotely related. But through this project, we are building capacity around gender and social inclusion policy, and building the capacity of the health sector workforce to better understand these issues and respond to them. So that's integrating into the medical curriculum, for example. There's also a research project on medical care for transgender and people with disabilities, and also training of teachers, including patient handling and the needs of transgender clients. So for the next one here, which it's all about better understanding of the data and the social determinants of health to be able to inform some good responses. So through that, there are, I think, 20 national programs that are being supported to have better data around the particular needs of vulnerable groups and women. And one of the interesting innovations that's coming out of that is a digital health intervention, which will provide a discrete avenue for access to mental health and tele-counseling, including for women and people of diverse SOGIESC. And on the last slide, just to say that, again, an increased focus on those most marginalized, and that could be marginalization for various forms of discrimination, intersectionality with gender. But the project on the left is really looking at migrant women in Cambodia and Laos, and we know that often migrant women have faced additional barriers to accessing health services. So through this project, we're building in multifaceted approaches, such as a portable electronic personal health record, so that female migrants are able to facilitate continuity of care, including their medical records. And here on the right is a resource that we recently published, which is actually multi-sectoral, about gender equality and disability. But some of the guidance in there which relate to the health sector talk about the need for capacity building for health workers, including in the sexual and reproductive health space, to provide rights-based care for women with disabilities, and also other forms of access such as telemedicine, accommodation where needed. So this is a very quick overview of the health sector. It does also touch on some other sectors, and one obvious one would be around water and sanitation. So looking at promoting proper menstrual health and hygiene through that sector. And just a quick flag that we are currently updating our gender and health toolkit, so that will be forthcoming in the new year. Thank you.
Super. I hand
Hand over to you. Yeah.
Thanks very much. So I'm sitting here representing the Asia Pacific Resource and Research Center for Women, ARROW. And ARROW is an organization who for like 30 over years has worked with national level and community level organizations on sexual and reproductive health and rights. So we work with partners who actually have gender equality as one of the focus, right? Simply because we see, autonomy over bodies as leading to greater gender equality in societies. And it is actually very essential to have access to sexual and reproductive health and enable women to be able to, women and girls and young women and young people, to exercise their sexual and reproductive rights and realize their sexual and reproductive rights within systems and policies which are at play. So I thought that, so Joanna actually said, oh, please talk about some of the work of ARROW. So we are across 19 countries and we work with more than 80 partners at national and community levels currently. So I thought I'll talk about three aspects where CSOs and women's rights NGOs, because everyone has talked about the role of CSOs, right? Where perhaps the work of our partners has actually made the greatest difference. So the first is about equity. Right. So a few years ago, we had a project across the Mekong region, and this is in Laos, Cambodia, and Vietnam in particular. And this was about working with youth-led organizations and youth-serving organizations, where these groups organized young people to make them aware of their rights and to know what their entitlements are. Right. And what these young people's groups did is they actually went to the local health services, right, the government-run public health services, and through their evidence and their advocacy were actually able to make those service providers provide youth-friendly services, right, to kind of destigmatize or reduce the barriers that young people, especially unmarried young people, have in being able to get sexual and reproductive health services from public services. So in the basis of equity, I mean, it's really important because it's actually the civil society and who are able to bring up these issues and make these equity concerns known. The second is, of course, around accountability, and in this, we also had a very large project in South Asia. And one of this is about how do we actually ensure that marginalized women are able to actually receive quality of services. Right, because we know for sure that when wealthier, more urban, more educated women go to public health services, we get a different type of service, and this is something that we need to be very aware of. Though we, so although the health service is there, but not all of us may get the equal treatment from the health service providers. So in this one particular area in Bangladesh, so they actually created hospital management committees, and in the hospital management committees, they put these women's rights groups, the community groups, to actually be able to track, what is the type of service satisfaction, what types of services were being offered, and some of these were very simple things, right? Because it's like introducing things like tokens. So you don't give them customer survey forms, but you either put a happy sign or a not so happy sign, and so it becomes the feedback mechanism of how women from more marginalized communities are able to give that feedback to service providers, right? So that was one of it. The third aspect I feel like where CSOs also play a very powerful role is the autonomy aspect. And because we are all often dealing with not just sexual and reproductive health service provision from like a welfare type of approach, but actually from an empowering equality approach, right? And I remember that many years ago, one of the partners who came to us from Maldives, and in Maldives, they have this genetically transmitted disease, thalassemia. Yes, that. Yeah, yes. And so because of that, and although the Maldives actually has a very abortion is criminalized, they did something very unusual, which is they actually went to the fatwa community, the fatwa, and they made a fatwa which allowed for, in the cases of this genetic transmission of disease, that abortion should be made available. So they actually started off on this premise, and later on they were actually able to widen the grounds for abortion. And many years later, when I went back and I met the group that was working on this, they actually even gave me this example of how there was a underage victim survivor of rape, who was then the High Court, utilizing this fatwa, made sure that the Ministry of Women took this young person to Kerala in order to provide, to access a safe abortion service for her, So these are the ways in which I feel like, so there's three key areas, right? Equity, accountability, and autonomy, where CSOs, where they're empowered, are able to actually provide more gender equal, gender sensitive health services. This is one of the roles, these are the roles of CSOs within gender equality.
Thank you so much, Siva, for that and those really interesting examples. We do have time for a short video, which I would like to share if it's okay with everyone. It relates to one of the case studies in the pack, and actually to one of the projects I think that Sam spoke to earlier. It's looking at gender integration into medical education, led by the Center for Inquiry into Health and Allied Themes. And I think it's really important to see and hear, what has been achieved very concretely in this space. So we'll just play the short video and then go for the discussion.
Medicine as a field has long been critiqued for being gender biased and not accounting for social determinants that shape health conditions, access to healthcare, and health outcomes. Gender bias does permeate many aspects of medicine in India, ranging from clinical practice to medical education. In the year 2014, Center for Inquiry into Health and Allied Themes, SEHAT, in collaboration with the Directorate of Medical Education and Research Maharashtra and the Maharashtra University of Health Sciences, embarked on a project which aimed to integrate gender in the undergraduate medical curriculum. The disciplines of gynecology and obstetrics, forensic science and toxicology, community medicine, internal medicine, and psychiatry were selected as they are considered core disciplines of the undergraduate medical curriculum. Medical educators were trained to integrate gender concerns into their teaching, make revisions to the curriculum, and spearhead the implementation of the revised curriculum. Assistant professors and associate professors from 6 rural government medical colleges and 1 private medical college were selected to become change agents. The participants played a key role in co-constructing knowledge. Lots of case studies, debates, and role play were employed to make the learning dynamic. All of this happened within regular teaching and working hours, so as not to add to the burden of these professors. A study was also undertaken to assess the project's feasibility. Was it possible to implement within the stipulated lecture time? Would students attend these lectures? Would these additions make a dent in transforming the knowledge, attitude, or practice of doctors? The answer to all of these questions was a resounding yes.
So I am going to read some sentences, and for that particular sentence you are supposed to tell me, is it sex related or is it gender related? Women menstruate. Sex, biology. Very good. Men are better at playing cricket than women are. Remember Smriti Mandhana, right? Women are gentle by nature. Gender, they are trained to do that, isn't it? The woman who is not gentle, immediately we start to are kasni mulgi hai, right? Men cannot do housework. And men cannot control their sexual drive. So we have a division of house, no? So let's do a vote. Who wants to say it is sex related? So you had change of mind. So are you sure it is gender related? Yes. Very clear? Yes. if it is sex related, it has to be same for every man. Is it same?
Medical educators accepted these gender integrated modules wholeheartedly because they found them complementary to the existing syllabus. Student attendance improved, and the entire training process resulted in a dramatic change in the mindset of the core group.
The university had decided that they're going to incorporate gender sensitivity into the curriculum and begin at the grassroots levels with first year students so that it happens. And we were happy to associate it with an NGO, Sehat, for this. If I have 150 students passing out every year, then they're going to work in the 50 other medical colleges in Maharashtra and maybe 500 medical colleges across the country. So if they have picked up even a bit of a spark, then that student is my ambassador there and also the ambassador for this cause.
I was a gender blind when I was groomed as a postgraduate student, as a faculty. But since last 4 years now we are gender sensitive. If I apply a gender lens to my further teaching, definitely I can do the justice to the students and the women also. And this is what the change we brought in our department. But still the medical education, now also the books, they are not gender sensitive. There are many books which are having still gender blind sentences. That has to be changed.
The Academic Council of Maharashtra has reviewed and approved this gender integrated curriculum, and a directive for implementation of the gender integrated curriculum has been issued in 2018 to medical colleges across Maharashtra. Till date, 300 doctors have been trained, and they in turn have transmitted this knowledge, attitude and practice to their students, to nurses, and of course their fellow doctors. A positive beginning has been made. Moving forward will require many more champions within each and every medical college.
Okay, so that was a good note on which to switch to discussion. By the way, that doctor, the one who said I was gender blind and became gender sensitive, is an absolute dynamo. I mean, he's like making sparks all over the area around him. And there's so much happening now around the medical colleges. And if I think about the work in my own center around this question of whether we can somehow break into the medical curriculum at all, and there'd be so much, oh no, you cannot, they will never listen, etc., etc. So this Sehat project just shows that it can be done, and that in fact we can turn what is can sometimes be a horribly not just gender blind, but anti-women practice into becoming far more gender aware, sensitive, and even transformative, because it's not only among the health workers, but it transmits then to the families of the women who come in, and they then have to deal with the health workers and the doctors who on these issues. So I think these kinds of sparks are can be enormously interesting. So we have about 20 minutes for questions and discussion, and we've had a very wide-ranging set of really interesting presentations that have covered a number of things. And just to highlight some of the ones that we've covered, the question of healthcare workers, and particularly frontline healthcare workers, came up in a number of the presentations that we've heard. And I think the question we have there is how this sits against a practice which tends to treat frontline and community health workers as unpaid volunteers in the system as part of macroeconomic austerity measures. And I think this is one of the reasons that if you look at that Lancet commentary,
which you all have copies of and which have been signed off on by the heads of 6 UN agencies and others, as I told you, that is one of the reasons that the third and to me, almost the most important of the points that has been made is that we need a mindset change among those powerful institutions that push austerity policies at the expense of the health sector and frontline health workers. So that was one issue. I think we heard a lot from Sangeeta from Nepal about the kinds of changes, including the importance of addressing cultural barriers and the importance of legal reforms, and particularly the reforms towards safe abortion in Nepal are by no means new, and they're not perfect by any means, but they've made a major dent in an area that we know has been of significant importance for girls and women. I think Sangeeta also stressed the importance of partnerships with civil society, which is another one of the 3 recommendations in that Lancet documentary. I think our deputy mayor from the Philippines spoke about unpaid care work. And in the first instance, you may have thought, well, what does this have to do with a session that is largely on gender and health? And of course, it has everything to do with it, because in fact, a lot of the unpaid care work that gets done in the home has to do with health, whether it is the health of babies or the health of older people or the health of the sick. A lot of the unpaid care work is exactly about that. And the ability then to apply the 4 hours of unpaid care to transform the meaning and the understanding of unpaid care is of critical importance in the health sector. Not to mention the fact that, not to forget the fact that during the COVID pandemic, when the paid health system was drowning in the pandemic, a lot of what happened, particularly for poor households and communities, was they were dependent on care in the home. And so what and how we address the challenge of unpaid care in the context of the health system, I think was brought out beautifully in that Philippines example. I was really excited to hear about all of the ways in which ADB is addressing many of what we might consider sort of avant-garde issues having to do with inclusiveness of different communities, and particularly giving importance to the need for financing health, which of course brings us back to the austerity policies question again. I think Shiva spoke about terrific examples of the kind of work that community-led and based organizations can do in providing models for how we can do this. So with that, and of course, I already said why I think the Sehat example is critical, because that's the community that we need to break into. Those doctors died in the wool patriarchs, many of them, when they are not dealt with, in fact, need to be addressed. And I think the Sehat case shows us that it is possible. It's not impossible. So I think that we've had a very dynamic set of presentations. So I want to open this up now to your questions, comments. If you're asking a question, please say who the question is for. And if you have a comment or an addition, make it crisp and short so we can take as many as possible. So who would like to start? And I don't know, Joanna, what we're doing about the online people. There, yeah, let's do this and then we'll take some from the online. So is there anyone who would like to start with a comment or a question? Yes. And just say your name and where you're from.
My name is Lakshmi. I'm from Nepal. Thank you so much for raising the issue on addressing inequalities in health, because in 2019, when I was in CSW, that was the first time the WHO has launched the report on delivered by women, led by men, a gender and equity analysis of the global health and social workforce. I mean, that was the first time, and this was the second time, because I have been keep advocating for this, because majority of, even the Lancet report has said, many of the frontline workers are the nurses and midwives and the community health volunteers who have not been acknowledged, but only they are appreciated in this international forum, which our minister also did so. But at the country level, when they were asked to compensate, you know, they have their own different view, and they are the one who has been working hard. You know, they don't have any time when they have to go in the community. They are there 24 hours. And I think it's so important to acknowledge them. And regarding the unpaid work, for example, my mother has an interstitial lung disease, and my sister is a full-time carer for my mother. I mean, since last 5 years. And I don't know how this can be, you know, compensated, or I think maybe needs to be calculated somewhere, because when we hire the nurse, how much it costs. I think in that way, government or international organization responsible for this area needs to be at least acknowledged and valued. And once again, thank you for everyone for raising this issue. And in Nepal also, Jeshi, which our additional minister also has said, gender equality and social inclusion, the first time they have acknowledged the, service providers. Otherwise, they only focus on the beneficiaries. But when I talk with the nurse, I just want to finalize. Yeah. When I talk with the nurse, because they are the one who, who treat a client badly. And I said, why do you do this? And they said, we are dominated and discriminated by doctors, you know, and because we are sufferer, and we
take it out on the patients.
Yeah.
Thank you so much. Do we have another? Yes. Can we keep our comments short? They're great points, but let's keep it crisp. Go ahead.
Thank you. I'm Heshin Park from the OECD Development Center, where we talk a lot about root causes around social norms and legal barriers. So I had a bit of question for Nepal, but also to the Vice Mayor, especially when you discuss about the addressing cultural barriers. I mean, obviously it's up to the governments and the legislators to really come up with the legal reforms, but legal reforms can also be conduced by social norms change and cultural barriers tracking. So how can governments also help shifting such type of social norms and culture, dismantling all these cultural barriers? Okay. And I thought it was really interesting, the SIHA project, especially when it comes to engaging men and boys, because it's actually a man doctor who talked about what can be done to be gender sensitive, especially in the medical center. So thank you very much.
Thank you so much. We're going to wait and come at the end for responses. So Vice Mayor, make a note of that question, but not now. We'll come back to you at the end. Anyone else? Yes.
Talafalava, my name's Mele, and I'm based in Samoa, and I'm with UN Women. And I have two questions. I'll make them both brief. The first question is, in many rural spaces, we have traditional healers, like in Samoa, ko Taulo Isea, and these are women. And more times than not, they are not encouraged to engage with the healthcare sector for those patriarchal norms that you mentioned. So I'd love it if you have some examples of where there's either been partnership or encouragement of traditional healers to work with the healthcare sector, so that these women who are oftentimes the only source of health in rural areas can be.
For whom is your question?
Actually, this is for anybody who can answer this question, more importantly. So it will have to more likely either involve civil society or where you're engaging with rural spaces.
Okay,
And then the second question is just for ADB, because I'd love to learn more about the infrastructure and resilience project that you did in Kiribati. Thank you.
Okay. Okay. Do we have more here? Yes.
Thank you very much. My name is Sylvia Wong. I'm with UNFPA Asia Pacific Regional Office based here in Bangkok. And my question is for ADB. I was very interested to see how you were looking specifically at the impact of climate change on women, girls, gender aspects, sexual and reproductive health. And from our experience, we know that that exacerbates their vulnerabilities. I would be interested to know more about your thinking on looking at the specific age vulnerabilities among very young adolescents, especially girls. We know that there's the impact of heat stress on pregnancy outcomes. But I'd be curious to know if you're looking into how the climate crises and the impacts might affect the cognitive development, the physical development, the socio-emotional development of very young adolescents, especially girls, because of gender dimensions. Thank you.
Okay. Joanna, maybe we can take a couple of questions from.
And just online, we have Rajeshwari Chandrasekhar, who is asking or really highlighting the importance of mental health services as well, and thinking about gender integration into mental health services, particularly following the pandemic. But they also had a question to the Vice Mayor from Philippines with regards to the social norm change and the intergenerational aspect. You know, how do you create tools to do that? And what is the time scale vis-a-vis, you know, achievements that have been made and longer term plans?
Okay, you want one more, or we can?
I mean, we have one more question regarding the Sehat initiative, but I think the case study, I can refer them to that.
Okay. Unless there's another burning, you have a burner, make it quick, because now I'm going to turn it over to the speakers.
I'll be really quick. I'm so sorry. My name's Bree. I'm from Australia, and I really enjoyed the panel. Thank you so much. This is actually quite a general question to anyone who wants to answer it. But in Australia, we have quite inequitable health outcomes, particularly with rural Indigenous communities. And the health outcomes are so drastically different between the normal, between the Eastern Australia and the regional communities. And I was wondering if anyone had any kind of advice or tips or lessons learned when engaging with rural communities and rural First Nations communities.
Okay, thank you. That's for anybody who feels up to taking them. So let's do this in reverse order. We're going to start with Siva, and everybody has 1 minute.
So on the overall, I thought that question was in a nutshell about social cultural norm change and the role of CSOs. I think that one of the things that happens is that, CSOs advocate for legal or policy changes. So that's the first step of kind of making sure either the service is accessible or the type, if they're not discriminated against, whether it's for example, unmarried young people, right? So I think that's one aspect of it. The second is, of course, a lot of, I think, work on the 70s and 80s among CSOs where Dawn is actually focused on community level behavior change, right? So there's a lot of awareness raising of like what things could be different, and that was really important because it kind of like embeds those rights within the community voices, the community realities, and then it works, I think, better in the longer run for that social norm change. And I think the most important social norm change is the vision of like someone as an individual from being a recipient of government services, right? A welfare approach to someone who's actually a rights holder and actually turning the service provider instead of someone who is a powerful person into someone who is, fulfilling duties or a duty bearer, so I think that's a big social cultural norm change.
Great, thanks.
Okay, so I'll be very quick, and maybe one of the best ways is Mele to give you an answer about the Kiribati project. That is one that's receiving money from our SDG 5 grant. It's an infrastructure project, but the SDG 5 is supporting the sexual reproductive health and the GBV. But I can probably share with you the project information online. Actually, all of the links were embedded in the presentation as well. On the question from, I think, UNFPA, this is the whole gender and heat stress is a very new area. There isn't a lot. We're not specifically looking at the issue of adolescent girls, but we are working with various health researchers and really trying to encourage more focus of the researchers that are looking at heat to take a gender lens on it, particularly those in the region, because most of the data that is out there is not from the Asia Pacific region, and it's obviously a different context because it's hot all the time as opposed to like a sudden European heat wave or something like that. And then just to comment on the mental health, it is a new area as well, but one example was what I cited earlier in the India Health Systems one, where a digital health intervention is supporting mental health as one of its objectives. I'll stop there. Thank you.
Okay, thank you. What we are doing in the shifting of social norms based on our implementation of our local legislation is that social norms is based on culture that was passed from generation to generation, from mother to girls, and that's what we are trying to break through in our orientations with students, in any ways that we can deliver this information. We always tell them that care work is a shared responsibility at home. It's not for mother that passed to women or from the father to a boy. It's a shared responsibility at home. Another is how can we integrate this shifting of social norms in a national level. We are proposing to add the 4 Rs. A fifth R is re-education. We embed in the minds of young children in the elementary. We can put it in another additional curriculum in the elementary so that they will start young in shifting of social norms. Thank you.
Thanks very much. And before I give it to, is Sangeeta still there? While you check that, I would just say that actually I think now we've gone from talking about young people to talking about older adolescents. Now we talk about younger adolescents. We've always talked about children. The age group that is not touched is the 5 to 9, 5 to 10. And that, I believe, is almost the most critical age group for gender norms, because up to the age of 4 or 5, kids, boys, girls, everybody is treated alike. They're all running around. At the age of 5 and 6 is when the little girl is given the broom and told, why don't you sweep outside, while her brother is running around playing with his friends and doing. So gender norms start getting imprinted exactly at that age. So you're absolutely right about the elementary curriculum. Is she still there? She's not. Okay. Yes. I just would like to address the point of your mic.
Laxmi, you raised the point about what kind of compensation or recognition can be given to a daughter who took care of her mother. And I just would like to relate it to what we are trying to do in the Philippines in regard to our proposed law. In terms of what is existing, there is a service from the Department of Social Services and Development, which is called Cash for Care. So if you are devoting your time to taking care of a member of a family and you have lost your income, then you can be given cash. But this is still in a very, very new stage, and they are coming up with a basis on how to calculate the amount that can be given to those who do the care work. And in terms of the bill that filed in the Senate, we have considered extending to the one who is providing care, the care worker, the services that are being given to other members of the society who are marginalized. For example, senior citizens have 20% discount in medicine and restaurant and all other expenses. So this can be extended also to somebody who is not senior citizen but is providing care to a member of a family. Scholarships also to the children of those who are. So this kind of services are already in existence, but we would like to extend it to those who are in the task of providing care to family members. And we are also exploring the possibility of providing them with special support, like if they get sick, who takes care of those who are taking care of the sick. So it's a special kind of arrangement so that they can also receive treatment. So it is a process. I have a very strong faith about the care economy that we are trying to develop in the Philippines. I think it will shift a lot of perspectives, and it's going to be supported also by norm change, because nothing can happen without norm change. All of our gender inequality problems are rooted on culture, and some of them are brought to us by colonizers. And we said that we just would like to claim back our original culture, where we do not discriminate and we do not make women and men fight with each other just because they are women and men. They are different, but they are equal. They have different purposes in society. So let's just be the best person, the best version of ourselves. Thank you.
Thank you so much, Chairperson. I think, the thing with norms is sometimes the things that are called traditional norms are not traditional at all. They've been made up. If you actually trace, you'll find they were made up 15 years back. And we're told, oh, it's for lifetimes, it's been like this. So norms come from all kinds of places, maybe from the colonizers, maybe from current patriarchy, maybe from, our own histories. And certainly in my country, we have enough of those that have come from our own backgrounds and histories. So I think that the questions are around how those changes can happen. I think you will agree with me that we've had really a lively and interesting, despite the time, we managed to keep you awake. And I just want to add one thing, which is an opportunity that I think we all have upcoming very soon. The upcoming 2025 UN Commission on Population and Development is on health. And almost certainly discussions there will be on UHC and universal health care, etc. But one of the things that we know about a lot of that discussion is that the kinds of issues that have been raised in the panel today rarely find a place in the discussions around universal health care and health coverage. And I think it's an opportunity to actually bring those discussions into that space. So with that, let me ask you to give a big hand to the panel. And we would also, you can give a big hand to yourselves for being here at this time. And now, thank you all for being here. See you tomorrow.